if we can, so that we can have a smooth meeting, and also if we can to keep our cameras off during the webinar. I would want to inform you that you have two platforms to be able to engage with us. One is using the chat, so you can post there, your name, where you come from, where you work, and what you do there, and also make any comments as we continue the discussion. But also you have another tab that is labeled as Q&A, that's questions and answers, and that's where you're going to post your questions, so that after the presentation you can be able to respond to those questions. Again, those two tabs, they should be at the center, or the bottom at the center of your screen. There is one tab that is chat. You can use that to post your name, post your organization, and what you're doing, what you're doing there, your health facility, if you come from facility, or you are any other organization, your entity, and what you do there. And then there's another tab that is labeled as Q&A, questions and answers. That's where you'll be posting your questions, so that you can be able to respond to them, or our speaker this afternoon can be able to respond to them after the presentation. So I think with that, I'm going to invite our speaker this afternoon, and I have the pleasure of introducing Dr. Angela McIlligale. Dr. McIlligale is a consultant physician and medical oncologist. She has a Master of Medicine in Internal Medicine, a MSc or Master of Science in Clinical Oncology from ULM University in Germany, and she also has a fellowship in medical oncology from the University of Nairobi. Dr. McIlligale has won the ASCO International Development Identification Award. That was in the year 2018, and is also holding the ESMO 5-year certification in oncology. She has over 18 years of clinical experience in general medicine and oncology. And Dr. McIlligale's core skills are in clinical decision-making, conducting trainings, medical education, research, as well as the development of treatment guidelines and protocols. So it's a pleasure to have Dr. McIlligale with us this afternoon. And Dr. McIlligale, welcome to take us through your presentation. Thank you.
Thank you very much, Valerian, for that introduction. And thanks to the National Cancer Control Program and the Department of Non-Communicable Diseases for the opportunity to talk about CML, which is important to us in medical oncology and in hematology. I'll be sharing my screen, so you let me know whether you can see it shortly. So good afternoon again. I'm going to begin right away. I think the preliminaries have been done by Dr. Valerian. So our topic for today is on the overview of the CML program in Kenya. I think the CML program has been in existence for several years, and we are really just looking to up our game in how and where we manage this disease. And as Dr. Mwendwa has said, we are going to be doing a series of these talks by different colleagues who are involved in the CML program, and just looking to involve more and more stakeholders because there's a lot of successes and a lot of lessons which we have learned that won't just apply to CML, but to other oncological conditions. So moving on is just really by introduction, looking at the GLIVEC, Global Patient Access Programs. And these ones were initiated over 20 years ago, and different models were being looked at. And I think I've just highlighted the middle one, where Novartis was looking at fully paying for GLIVEC after its great success and after its FDA approval for CML. And so it was not just this particular program that was important, but this is our area of interest today. And then again, in more introduction, before 2001, CML was actually a life-threatening disease. And I think for anybody, and in Kenya, we have a lot of oncology The cases are going up every day. And so if you know cancer, it's still really a life-threatening condition based on the data that we have currently. And so CML was no exception. And during these days, before 2001, it was treated with radiotherapy, with hydroxyurea, cytarabine, busulfan, interferon alpha. And really the only hope for cure in those days was allogeneic stem cell transplant. And a lot of the patients who had CML at the time had a median survival that was less than 5 years. And you know, this picture is just like really what we see right now in a lot of our cancer patients. And the successes we have with CML really should be an encouragement that we are able to really do better even with other cancer conditions. I think where there is determination and research and implementation, successes can be realized. And then talk a bit about Gleevec because it was really the game changer. And this drug was developed and marketed by Novartis, got FDA approval in 2002. And the main disease conditions for it is chronic myeloid leukemia and gastrointestinal stromal tumor, which is a sarcoma that mostly develops in the GIT. However, the indications for this drug has improved and increased. We're using it in acute lymphoblastic leukemia, that is Philadelphia chromosome positive. And sorry for all the abbreviations, I'll just try to mention them nicely. And then of course we have a disease, another sarcomatous disease called dermatofibrosarcoma protuberans. So we give patients with this disease condition imatinib. For patients who have myeloproliferative neoplasms, especially when it is co-occurring with myelodysplastic syndrome. So that's the MDS-MPD, and also for systemic mastocytosis, plus other diseases, which I did not mention. However, you know, this drug, just like branded products new in the market at that time, was quite costly, almost costing $500,000 per month, and therefore not accessible to resource-limited countries. And therefore, the Novartis leadership in 2002 established what is called the GPAP program. And the main goal here was to provide Gleevec to patients who were in the low-income countries and could not afford these drugs. Along with that, of course, our health insurance schemes would not have been able to cope at that time. In 2002, NHIF was not in existence. I think many young oncologists don't really know that NHIF only started to function for us in 2016. So at this point in time, patients were actually having to purchase. But even if NHIF had been operational then, 400,000 per month would never have been covered. I think the max that we get from NHIF right now is 100,000 per month or per cycle of treatment. When it was established, it was not just for Kenya, it was for any country that was eligible globally. Currently, the program has expanded, supporting about 75,000 patients cumulatively, with a network of about 1,400 physicians, and about 80 countries have enrolled into this. So the full name for GPAP is the Gleevec International Patient Assistance Program, but this has since been renamed the Max Access Solutions, shortened as MAS, MAS. And so I'm just going to talk a bit about the stakeholders, because we're just looking at the program and trying to understand it, even as we look at how it has worked for us in CML. So some of the stakeholders in this program, I think key kabisa is Novartis Pharma. So Novartis is important because one, they developed and marketed the drug, but they made the decision then to be able to provide it and fund that provision so that they actually give these drugs for free at full pay. In addition to that, they fund the shipping costs. Initially, they actually managed the supply chain that involved distributing the drugs to the patients who qualified at the various treatment centers, but the supply chain management bit was handed over to the Max Access Solutions program. Novartis is very key also in interacting with local stakeholders in the countries that support CML patients and at these centers. I think personally, from the time I have worked in the GPAP clinic in Nairobi, I have always had within the clinic, when we're running it voluntarily, someone from Novartis staying on throughout the clinic and at no additional pay or overtime, same way that we do. So they're really actually very, very involved in that program. Also, they were initially quite active in applying for tax exemptions because, I mean, government being government still imposed tax despite this being a donation. And sometimes this took a bit of time and caused a bit of stress. But right now the tax aspects have been handed over to the Ministry of Health, which is a good move. So number two, in terms of the stakeholder here is the Max Foundation. So the Max Foundation is a US-based cancer NGO, but it has a very good international focus. As we said, you know, the MAX program is being implemented in over 80 countries. Max, of course, is derived from this young boy who was called Maximiliano Rivarola. And he was diagnosed with CML at age of 14. He lived for about 3 years. There was no imatinib, so he did pass on. And then his mother started the Max Foundation, really to just support patients who have CML and to try and ensure that nobody dies from CML if it is avoidable. So it was really very philanthropic of her. Right now, Max is, other than their support to the patients, which we will talk about, are currently also fully implementing the drug supply chain in partnership with Turner Pharma that helps them with the shipping logistics. Along with, you know, just having initiated such a program by working with Novartis and handling the drug logistics, Max is currently fully responsible for reviewing the applications for imatinib patients. So whenever any of us clinicians are enrolling any new patients, the documentation for that patient is inputted into an online platform, which is then assessed by Max Foundation coordinators. And Max actually has the final responsibility for processing and assessing eligible patients into the program. In addition to allowing for application and approving applications, they also follow up and reevaluate whether a patient is still eligible, whether a patient has dropped out and needs to be removed from a particular treatment center. And I think many times I get messages that, you know, they're about to drop off several of the patients who are under me, and I'm like, gosh, I even forgot. And so they're really actually still quite active in that. They also provide information concerning adverse drug reactions to Novartis so that this can be reported to relevant authorities like the Pharmacy and Poisons Board. They also look at emotional support and education and referral assistance to patients. And then for us in Kenya, the Ministry of Health is really, really involved. And just to be clear that this particular webinar has been organized by our Ministry of Health, which is now like a very key partner and has signed an MOU with Novartis and with Max Foundation and really wants to support patients who have CML in Kenya. And some of the activities, one is via KEMSA. And KEMSA, once drugs are shipped into the country, is responsible for delivering these treatments to the local qualified treatment centers. And we shall look at those centers in Kenya later on in this presentation. In addition to that, we have the National Cancer Control Program, who is really hosting this webinar and is looking towards further webinars and quality improvement for CML patients, and we really appreciate their involvement. So as I've said, NCCP is really fully partnering with Novartis and with Max Foundation to ensure success of the CML program. They're working hard to ensure that there's tax exemption. We've had issues before with the government imposing tax, and then the drugs become, you know, having a cost implication to patients and also delays in reaching the treatment sites. But this has not been an issue right now, thankfully, because government is now part and parcel of the program. The National Cancer Control Program has really also been key in the decentralization exercise. So we know that GPAP has been in the Nairobi hospital for the longest time and at Aga Khan. And all patients who had this disease had to travel to Nairobi. But Now we have 4 county hospitals, and this is really courtesy of the National Cancer Control Program, and we are implementing. And this activity is ongoing. We shall look at some of the data. Awareness creation around CML. This is just the first of many, and we are looking at this being sustainable and continuous so that we can win this battle around CML. And of course, they're also looking at quality improvement, where best practice sharing that will happen between Nairobi Hospital and these county hospitals that are currently decentralized too. A bit about the GPAP model. As I said, it is a full pay model, meaning Novartis fully covers the cost of treatment. I think it's important to emphasize that there's no CML patients who will be told to pay for imatinib. And not just imatinib, but there are also other drugs which we shall look at later on in the presentation. However, patients are expected to pay a consultation fee. I think at Russia, when we initially launched, Jaramogi Oginga Odinga Hospital, the CML program there, because patients used to come to Nairobi Hospital and they'll just register and not pay anything. We struggled a bit with just having our patients agree to pay the 50 bob for opening a file. And well, eventually I think patients adjusted and now they have no problem. I think the big challenge that it's something that's also an opportunity to look at is that lab tests are not covered, unfortunately. And we know that the molecular tests for diagnosing CML and even gastrointestinal stromal tumor, they're quite costly. So this is still really on the patient. So they still have to pay for that. But the emphasis is that drugs are free. And I'm saying this because, again, I have seen patients in private hospitals who have CML. Sometimes I'm very shocked because we think there's enough awareness that there's a free program. And patients are using either cash or generics or something. There are all sorts of models. They're not wrong. It's just that sometimes it's surprising. I think it's good to keep an open mind. But it's also that those patients don't know. A few of them have referred them and they've been happy to move over to one of the county hospitals. Now the GPAP model applies, and forgive me for calling it GPAP, now it is MAS or MAS. It applies a unique direct to patient approach, meaning that the applying physician will give all the details of the patients, and then Novartis and Max Foundation works to provide that medicine for that patient at the dosage requested by their physician at the qualifying treatment center. So that's what I mean by direct to patient, without having multiple stops and brokerage in between. And they really try to operate this still within the existing healthcare system for each country that is being supported. For a patient to qualify, and I think this is also important because we are looking to have patients enrolling at the county facilities. You need a GPAP qualified physician to make that diagnosis, or someone who has already been allowed to be a GPAP physician. So the diagnosis can only be made by BCR-ABL. I'm not saying it is a GPAP physician to do this test, but many times I get called and the patient doesn't have the test. So when you're seeing your patient and you do the BCR-ABL, the patient can come with it. If you suspect CML or GIST and you don't know what test to do, you can still refer the patient to the GPAP teams to be able to run these molecular tests. But there's no patient who will initiate or be enrolled without them doing their molecular tests, unfortunately. And you know that the tests are running between anything 12,000 Kenyan shillings to 25,000 Kenyan shillings. And of course, know that the government is our partner. We are really looking at NHIF and also any labs that can really support this for our patients. Then once a patient is diagnosed, they can be referred to the treatment center for enrollment. And usually the centers have already been pre-selected. And for us in Kenya, we shall look at our centers. And the biggest qualification is that there's somebody who is supporting, who is qualified in hematology or medical oncology, supporting that facility. As I said, the application is done online on behalf of the patient by the the GPAP or the MAX clinician. And usually then once you apply, the MAX Foundation coordinators are able to access that and then able to give approval. The physician who is managing the patient needs to be as involved as possible in the diagnosis, prescribing, treatment, and follow-up of the patients. So that is really the overall model. It's applied globally and replicated even within the Nairobi hospital and Aga Khan systems. And as I said, this was established in 2002, but for us, really, I think it was mostly from, 2005. That's when it has been mostly active. All patients in Kenya are currently accepted, even those who have private insurance, although maybe that should be relooked at. And from my data review, I've looked at CML data quite a bit. Around 1,500 patients in Kenya have benefited from this program. Currently, and just looking at how the program has grown, there are about 10 to 13 doctors, mostly medical oncologists and hematologists that support or have supported the CML clinic at Nairobi Hospital. And always, of course, the pharmacists and nurses who work with the team. I'm not going to talk too much about Aga Khan. It's run by Professor Riyad, and it follows the same model, but I'll focus on Nairobi Hospital because it has majority of the patients and majority of the GPAP doctors, but also the fact that it does offer this administrative framework, provides a secretary, provides a pharmacist, provides a space, and patients are able to come every 2 weeks. And every 2 weeks, there are almost 200 patients who need to be seen. And sometimes I look at the WhatsApp group and I feel sorry for my colleagues because you might find there are 1 or 2 people and 200 patients. So not all these 10 to 13 medons or hematologists are always available at any one time. It's purely voluntary. It's totally free. It's done on a Saturday. Sometimes it can take your entire Saturday. And that's why we are doing some of these, so that you can look at how do we make these, more friendly to patients, because patients are waiting the whole day to be seen. Really, it is not an ideal setup. In Nairobi, the application is done under the 3 pioneer consultants, but just to be clear that we have 4 county hospitals, and at these county hospitals, new patients can be enrolled. So we don't have to send patients to Nairobi to be enrolled. And to enroll a patient, of course, you're going to input all their data, and it takes just about 24 to 48 hours to get a response that the patient has been approved and can join the program. Most patients require Gleevec 400 milligrams once a day, and at enrollment, patients get a 1-month prescription and are given a clinic. Usually the first visit, even if they do go to Nairobi Hospital, they'll pay consultation fees, they'll do their labs, but the medicine will be free. Subsequent clinics are free. Now, these are the voluntary Saturday clinics that I have talked about, but patients do pay to do their blood counts. To help us monitor for toxicity. We know that imatinib, one of the main things it can cause is cytopenia. And so we are able to identify that by doing their complete blood counts. Patients sometimes require dose adjustments when they develop toxicity, so we do that when they come to the clinic. As I said, patients once enrolled are not permanently within the program. You as the enrolling physician you have to keep doing reapprovals for them to continue on Gleevec, because one, patients can drop off, patients may die, patients may have dose adjustments, patients may be lost to follow up, and so being an expensive treatment is just good for audit purposes to reassess and reapprove. And also updates on dosing and toxicities and any other outcomes are done when the patients come. So we look a bit around decentralizations and the numbers that have been enrolled and contact persons. And I'm sorry, I'm not going to talk about contact persons, but even at these 4 facilities, this is the Jaramogi Oginga Odinga Hospital, Moi Teaching and Referral Hospital, Nakuru County Research Hospital. I don't know whether Nakuru is a research referral, like maybe. I'm not sure at which point I disappeared. I discovered I was mute. Valerian, was I being heard?
Angela, you just disappeared like for 10 seconds, so you're fine.
Okay. I think it went on mute by some method. So I was saying that even at the decentralized facilities, same global model is being followed, and also the same Nairobi model. So we are not perfect. I think we are looking at how can we improve even at the county hospital so that our patients are happy to be decentralized and to be referred back to the nearest places. This is easier for them than having to travel to Nairobi. It's better for adherents. And I think the National Cancer Control Program, the MOH, is keen to ensure that as much as possible, quality is similar to what they would get if they were to go to Nairobi. As I said, even in the county hospitals, they will pay for the fine and they will pay for the tests, but the medicines will be free. So this is just a table looking at how the patients have been enrolled. And I'm just gonna remove video, hopefully, yes, so that I can see the numbers. So in as far as where new patients are concerned, Nakuru is their leading, has enrolled 17 new patients. I modified this a bit, because I know the Jaramogi data. It was not reading the way I know it to be because I've enrolled a few. So there are about 8 new patients, and these are both GIST and CML. I think only Nairobi Hospital has put an ALL and a systemic mastocytosis on treatment recently. Coast has about 4 patients. And then we have 1 at MTRH, but I think some of these things have to do with data. So I think the reporting could improve, and I'm saying this because I think I may not have properly kept the data for GeoTRH around these new patients. Unfortunately, too many patients are going to Nairobi Hospital. Still, you can see we have 80 in the year since decentralization. And these are not Nairobi and Kiambu patients, let me say central patients. These are patients from all over the country. So a lot more is needed to be able to have patients go to their nearest facilities. And when you look at the total numbers at these facilities, Nairobi Hospital is still gasping, okay? That's what I was saying, like at each clinic, there are almost 200 patients for some interesting reasons. Despite decentralizing a little bit, the number of patients per clinic at the Nairobi Hospital keeps remaining at about between 150 to 200 per clinic date. And these doctors, they can be 8, but sometimes they can be 2, sometimes they can be 4. And very rare to find 8, so many times it's a bit overwhelming. Then Nakuru has done pretty well. They have a total of 71 patients. Jaramogi has about 50, MTRH has about 42, and Coast has about 19, giving a total of about 1,300. But as I said, this data is a little fluidish. Many times, I think it's even close to 2,000, and it's just a data issue. I can go back to video because it was closing a bit on my table. So we'll just look at some of the highlights, not all of them, but some good highlights. As I said, over 1,500 patients have been served. Decentralization has been successful. We are not having the numbers that we want to have out there, but for year 1, there's quite a bit of a few patients who have allowed themselves to be transferred, and a few new ones who have allowed themselves to be registered out here in the counties. I think a big success is that last year we established the CML registry. It just has the Nairobi data for now, although some of the patients who are decentralized are part of this registry prior to the transfer. and I'll show you a bit of what the registry is doing for us. The program has been handed over to MOH in partnership with Novartis, and this is good for sustainability. This thing of always being helped and we are not taking part. Where CML is concerned, it is not going to be a true statement. Our pharmacists are able to do reports so that they're able to get drugs replenished in good time. CML is one of those programs where we've had retention and compliance rates going close to 80%. And this is because patients are happy when they improve, and therefore they know that the treatment is useful. Patients themselves have come up with it's a nationwide support group called HENZO, which creates awareness around CML and GIST. And HENZO is a very successful support group. I think they're well-funded. Hello, Mapel, if you are here, you can concur. But it's one of the really well-organized and well-run support groups. And I think I'll just encourage any patients who are in this meeting that if you can join HENZO and you're not part of HENZO, please do join, and even the healthcare workers. And then, of course, another highlight is that now that MOH is involved, more awareness activities will be ongoing, and I think Novartis is open to supporting that. I'm so sorry, just allow me to put my charger on because I think my computer might go off. I'm so sorry, give me 1 minute. Sorry.
Maybe as Angela connects to power, just to remind you, especially the ones who have joined us after we started, welcome to this webinar focusing on CML and the CML treatment program in Kenya. Continue putting your questions on the chat so that you can respond to them after the presentation. Thank you. Back to you, Angela.
Sorry about that, so I'm back. And then lastly, of course, other than imatinib, there's been a good expansion in the drugs which are provided and the diseases which are covered. Personally, sometimes I've sent my lung cancer patients for a drug called crizotinib, pazopanib. So there are more drugs available within the MASS program. At county level, we've seen new patients being registered, and we've also seen the number of referrals going up, and the patients who have been referred are still adhering to their treatment. And I think Nakuru level 5 has been highlighted quite a number of times for having a dedicated CML clinic. I support the Jaramogi one. We don't have a dedicated CML clinic, and I think our CML patients are not too happy to queue with our other oncology patients. We have a dedicated date, but that date is combined with other oncology patients. So Nakuru has a dedicated CML clinic, and they do try to provide a one-stop shop, do counseling, nutritional care for patients who are having CML. So that is good, Nakuru. And I hope the rest of the hospitals can learn from you. I just wanted to mention that CML is still a predominantly male disease, predominantly middle-aged, but we do have patients as young as 6 years within the program. The difference is not too big, but the male graph looks a bit more. And I put this to show that, in oncology, our data has been horrible, and that's putting it mildly. And CML being one of these pioneer diseases that have given us good programs and outcomes. It's also one of the ones with the registry right now. And we just need to look at how to then support that registry to continue. So Novartis, kama mnasikia, we are still looking at you to support. So the registry was supported by Novartis, and they're still looking at how to sustain that. And then this is still from our registry, and you can just see that, as I said, retention has been quite good. 5-year retentions are above 75%, close to 80%, meaning that the program really is successful. And then, of course, mortality is is low. This is one of the disease successes. Sometimes when I see a CML patient, a new one, I tell them, like, if you were to choose leukemia, then you'd probably choose a CML. If you're in that situation where you have to choose something bad, this is probably one of the best ones to choose. So mortality is pretty low. About 97% of the patients are still alive. You know, I don't even know how many months or how many years is 216 months, yeah? But those are several years. So patients tend to live quite long with their CML. So not a bad outcome. Other drugs, I've mentioned them, that have joined this bandwagon for imatinib, and they're available. Unfortunately, in the county hospitals, only imatinib is provided. So for patients who require any of these, either for second line in CML treatment or other diseases like crizotinib for lung, pazopanib for renal cell carcinoma, well, these ones we send them to Nairobi Hospital. So I'll talk about some of the lessons. For the longest time, our government has not prioritized cancer. It was HIV and was still under donor support. So we are still looking for the government to, you know, call cancer an epidemic in Kenya and to put the necessary infrastructure and the necessary funding and just take over a lot of the cancer treatments as possible. And we are happy, MOH and MCCP, that you're directly supporting the CML and really even pushing this agenda. Even this webinar is your effort. We still have limited health infrastructure, even in Kenya, in terms of diagnostics. Sometimes I've had to send blood samples from Kisumu to Nairobi Hospital. And I say, Kobaya, the lab people, if you're listening, because Nairobi Hospital will charge my patients 11,000 to do a BCR ABL. But in Kisumu, where we have Lancet and Aga Khan, it might go up to 17 or 23 or whatever. And so that is still a bit of a stressor. But I think MTRH now is able to do BCR ABL with NHI. I hope that can be confirmed. And then full tax exemption was not always obtained, but I think this has been cleared up. And we no longer have delayed treatments because goods are stuck or drugs are stuck at the port. Culturally, you know, sometimes patients feel better, and patients do get better on imatinib. And once they feel better, we find that they discontinue treatment or they stop adhering to treatment, and that can be a challenge. I put in dark that really the biggest issue here is doing a longitudinal care or follow-up for a patient who is well. Because these patients, despite their CML being present, many times, even before they go into remission, they're in perfect health. And so sometimes looking for them and maintaining them in treatment becomes a little challenging. And I'm just going to mention that, you know, CML is, in the Western world, it's looked at now as curable, even with imatinib. And there are patients who have been able to stop the imatinib. But also just to mention that in Kenya, we have not gotten there yet because we don't have the infrastructure and the platforms to be able to follow up our patients and return them on treatment should they lose their cure. Cost of molecular tests, that's the BCR ABL, it's too prohibitive really for most Kenyans. And we're not able to monitor our patients every 3 months the way we should. Many times we monitor once a year or once in 2 years to check that they're responding. Patients may lack money to travel for clinic appointments. It's a bit better now with the 4 county hospitals. The transport money is required is much less. But sometimes even in Kisumu, you see patients coming from Western Kenya, they're coming from, you know, Homa Bay area, and that still requires a bit of money and further decentralization is needed. We do have a few patients who have resistance to Gleevec, and sometimes we require, you know, even more molecular tests to be able to diagnose and to know which second line would be appropriate. We cannot do this, definitely we cannot do this in the peripheral facilities. And even in Nairobi, it is a huge challenge that many times we can make the decision of treatment failure based on BCR ABL, as opposed to looking at mutations. I think for us in the counties, there's inconsistencies in dispensing logs from our pharmacies, and this can interfere with smooth flow of our commodities. And then awareness around the JIPA program is still missing. I sit in Kisumu and enroll patients into Jaramogi Oginga Odinga, but many times my colleagues and other doctors will still refer patients to Nairobi, not because they don't want patients to come to Jaramogi, but because they are not aware. And I think my discussion with MOH and with Novartis is that we need to make this awareness sessions more continuous so that patients don't have to travel. This is just a bit of one of those challenges where you're not always able to maintain patients. Despite those good outcomes that I showed, sometimes you have patients dropping off. Either they have died, and for patients who die from CML, it's a little tragic. Maybe they've been lost to follow up. Sometimes the doctor has not provided information. Like me, I'm always having a threat on my email about my patients being dropped off. Yeah, I think those are some of the main reasons, and they continue here. These are just still some of the reasons. Just looking across all the available drugs, MAS program does quite a good job in trying to track what is happening to the patients. Looking at some of the opportunities is that we just want MOH to be more and more involved in our CML work and in decentralization and in sensitization, both for the patients at community level, at healthcare facility level, healthcare workers to be sensitized, so that as much as possible, our patients can get the support that they require. I know currently Novartis is doing full pay for the drugs, but for sustainability, it will be good to explore what NHIF would be able to do. I know currently they pay for nilotinib, which is a second line, still from Novartis, but it's good to just explore further how much more NHIF can contribute for sustainability purposes. Then, of course, opportunities like what we have right now for awareness creation, opportunity to support investigations. MOH, I think you're establishing labs, all right? And then just looking at other partners that can help to sustain this program. Then where the decentralization has happened, I think it's just to encourage those centers to take full ownership. So the program now is ours. It belongs to the Ministry of Health. It belongs to the counties. This is what is good for our patients. As long as the technical support is there, the centers need to own the program and just run it the way that we run other oncology clinics. So long as I think there's a hematologist or a medical oncologist supporting it, it's quite important for that ownership. It cannot continue in Nairobi Hospital indefinitely. And I think for now, Henzo Kenya, which is our star patient support group, to really look at supporting patients to be able to accept, to be decentralized. Some patients fear that they will not get the same quality or that they will not get the medication. They will not get the same psychosocial support if they move to the county. So we need you to encourage our patients to be able to enroll at county facilities. And then just the support, supervision, and QI being done jointly by MOH, by KEMSA, by MAS program, by Novartis, to be able to understand the challenges we face out here in the counties, so that they can be streamlined and our patients can be more comfortable. And in terms of a closing statement, I'm coming to the end, is that cancer management is costly. You can see how imatinib came from being a drug that costs almost $500,000 per month, and being inaccessible, with patients having very low survival of less than 5 years, to being a drug which is available and accessible even at the counties, to having patients living even up to 10 years, even in this Kenya, they're living up to 10 years and beyond and getting cured. There are a few patients in Nairobi who have stopped the imatinib and are being followed up and they are doing well. And so how can we use the lessons from GPAP, from MAS program, to apply to other malignancies so that cancer stops being, stops having poor outcomes like we have been experiencing. And just to say that a lot of successes have been documented for this particular cancer. And as I always say, it's the cancer that one would probably choose if you are choosing amongst many to have. And we are really happy about the successes. So asanteni sana. I would like to end there.
Thank you very much, Angela. Wow, I have to admit, this is one of the few periods we've had a discussion around cancer, and it was not all, sun as a gloom. Thank you, Angela. I think you've been able to break it down for us. There's so many people keep hearing, the term GPAP. Maybe they initially they didn't know what it means. Now you're breaking it down for us, and also thank you for really highlighting a story of hope. Again, knowing all the discussion around cancer, not just in Kenya, but also globally as a disease, that can quickly overwhelm both families and also health systems. But I think this afternoon you've stated, a real story of hope, which started from pain. I mean, it's from the death of Max, the young boy, but it's again as transcended that pain and caused life-changing interventions across the world. I think also you mentioned the issue of decentralization, which is aimed at reducing the pressure at Nairobi Hospital, especially the team of physicians there, and also reducing the burden of patients having to travel for follow-up to Nairobi, every time they're scheduled for that, but which unfortunately it has not picked up as we'd want to, and that's one of the reasons for us engaging in this series of webinars. And maybe, to cap it all, survival of more than 97%, it is good you demystify that, because I think people are quickly looking at the Kaplan-Meier and thinking, oh no, I'm seeing it dropping sharply, but actually it was plotted from 97%. So 97% of patients surviving 10 years and above, and this is here in this country, not in the West or in the high-income countries, as we keep doing comparisons between our contexts and the other better contexts. So really a story of hope across the board. So thank you for that. So I think we're going to move on then to look at the questions so that you can be able to respond to them. So I'm going to look at the Q&A section, and I encourage the members to continue, the attendees to continue putting your questions there. So the first question, I can see a number of questions touching on the CPDs. So, so since that's not the focus of our discussion this afternoon, I would request the technical support team at KNH, UON, the ones who graciously provided this platform to us, to check out that so that they can see how that can be addressed, so that members who will not receive CPD points for previous webinars can be able to get that. So I'll start with a question from Mercy June. So Mercy is asking, let me just read it verbatim. I had a patient or relative, 58 years, diagnosed with AML, so not CML, but AML, that's acute myeloid leukemia, but deteriorated with severe anemia, succumbed within 4 months, was a non-hypertension patient. Because of her religion, she couldn't transfuse, so maybe she couldn't accept transfusion of blood. Are there any non-blood options for such patients? Angela, maybe you can take that. I know it's not on CML, but maybe you can take that.
Thanks. So that's a very complicated question, because of course, knowing AML, not only did this patient require red cell transfusion, but also platelets, because they tend to have very low platelets. And we don't have in Kenya alternatives to blood. Even, the group that we know, and maybe she was in this group, Jehovah's Witnesses, we don't really have too many options. But some of the things that one can consider based on how your complete blood count looks like, that then gives a suggestion as to what could be lacking, or that what could you add to that patient that might build their counts up, is one, iron sucrose, one of my favorite agents, because iron deficiency is common in Kenya. Erythropoiesis stimulating agents can be considered, but many times you have to do APO levels, erythropoietin levels, and many times I don't do erythropoietin replacement unless their levels are less than 500. For patients for surgery, and this is not that situation, of course, you can do autologous blood donation. I'm just mentioning that because you're asking me a very hard question. For low platelets, many times you end up giving patients tranexamic acid, cryoprecipitate, immunoglobulins, albumin, but there is no, not to make it simple, there's no alternative to blood right now. So all those agents are just really to try.
All right, thank you. I must say that answers you. The next question is from Margaret Ngari. So Margaret is wondering, I thought the Gleevec drugs are now given through NHIF. Angela?
Well, so yes and no. So majority of CML patients actually having Gleevec for free through this full pay or full donation by Novartis Pharma. So I almost can end it there, but because I also work in the private sector, I have seen a couple of patients who are getting the Gleevec via NHIF and via private insurance, but not Gleevec. They are using a generic because that's what can actually fit within the NHIF maximum approval per month. But the people who are getting it via NHIF are few, a majority are within the MAS program.
Thank you. And again, one of the reasons we're having these webinars, so let's create awareness about the GPAP program so that patients can benefit. The next question is from who? This is Charles. Charles, I think, was wondering what the topic was. Oh, Charles had joined some nearly half an hour past the time we started. So Charles, we were discussing the CML treatment program in Kenya, the chronic myeloid leukemia treatment program in Kenya. And so you've not really missed everything. This is a series of 3 webinars. So I will, as you can, before we close, I'm going to give you the dates for the next 2 webinars. The next question is from Joseph. So Joseph is asking, because it's free medication, can the foundation train more medics?
That's one of those opportunities that I mentioned. What I can say is that currently the foundation is working with existing physicians who are also medical oncologists, hematologists, and we also have clinical oncologists. So the foundation is willing, I'm sure, to do on-job training, and it's one of the things that we are looking at in terms of expanding the care for these patients, that how can on-job training be done to keep the skills of doctors who are seeing GPAP patients up. But training is really broad, so I'm not quite sure, Joseph, whether we're talking about the doctors themselves who manage, or is it the pharmacists or the nursing, or is it the entire healthcare worker team? But I think it's a good input that we shall take up with Novartis and with Max, because I think everybody who's working in a GPAP setup really do need to train and to have continuous professional development.
Thank you. So Esther Samuinga, appreciating the update. She's asking whether there is a helpline in case a healthcare provider needs further guidance or direction concerning the program.
So we currently don't have a helpline. So
okay,
yeah, we shall look into that.
Yeah, I was actually about to say that actually that's a very, very good suggestion, especially in the context of decentralization, so that, you know, to give more information to healthcare workers to counsel the patient that, you know, the care being decentralized to these 4 county referral hospitals is basically the same program, same standards of care, same follow-up. You will continue receiving the medication to allay any anxieties. Okay, so there is another question. Is the drug still available for free for patients? I think, yeah, that's Angela, you've covered that within your presentation. Yes, the drug is free, even within the decentralized sites, the 4 decentralized sites. Daniel is asking, can CML spread to other organs of the body?
So that's an absolute yes. I always say hematological malignancies are disseminated as soon as they, not as soon as, but at some point in the disease journey. Because CML is a blood malignancy, meaning onset is usually from the bone marrow. And we always say we have bones all over the body, much as only some of the marrow is active, but mostly by the time you're diagnosing this, it is a disseminated disease. And then you have other, what I call the secondary hematopoietic organs, like the spleen, the lymph nodes, which are spleen very commonly affected, lymph nodes and liver, yes, and not as common, but yes, can get involved. But CML can also affect the skin, can affect the eyes, can affect definitely other organs. I think to answer you, the answer is yes.
Thank you. The next question is from Irene Olo. Irene is wondering whether, so thank you for the presentation, and then wondering why Novartis chose to fund CML out of all the different types of cancers. What's made or makes CML unique compared to the other cancers?
I think Novartis developed a drug that was targeted towards a genetic mutation. So CML is, you know, the good thing about this disease is that is at development, usually just this one mutation, the one you call the BCR-ABL occurring because of an exchange between chromosome 9 and 22. And it tends to be just that one. So that if you find a medicine or a drug that can just target and block it, then you stop that proliferation or that division or growth of that cancer. So that's what makes CML unique and easy to target. And I think for Novartis, they chose to fund CML because they were able to develop this drug. And then once it was tested, it was found to give these amazing outcomes that had not been experienced before. But now it was now good and a wonder drug for CML, and it's even curative really, and that's the truth, but not accessible. And so funding it made sense on that philanthropic level.
Thank you. I think the same person, Irene, is also asking, have you mentioned a ratio of 1 to 200 doctor to patients? Is there any dialogue with MOH towards training more medical officers in oncology, hematology at the master's level?
Valeria, take that.
Yeah, so yeah, I think I can. I think my simple comment will say yes. There's a lot of commitments and efforts being put into building capacity for oncology, not just CML, not just one oncology disease area alone, but actually the entire cancer control workforce across the country. And not just curative, not just treatments, also the other aspects of the cancer control continuum. So I do know as part of our next National Cancer Control Strategic Plan, the focus on health workforce and also diagnostics, which by the way, Angela mentioned as one of the challenges facing this program. They are key areas of focus. And this was highlighted from an impact evaluation that the country underwent last year from the UN agencies. So usually this kind of an evaluation that informs countries where they are in planning for cancer control within their jurisdictions. So yes, a lot. I may not be able to outline everything now, but it cuts across having local training programs and also having partnerships for training with other countries that have training programs that the country doesn't have, and also seeking a way of equitably having this workforce decentralized also, because as you are aware, there's a policy of action decentralizing cancer treatment and follow-up, not just CML. So we have the regional cancer centers. So it's not just training workers and then having them concentrated in major urban centers, but also ensuring that these trained health workforce, oncology health workforce, is equitably distributed across the country. All right. So the next question is Dorothy. Dorothy is asking, actually, she's appreciating your presentation, Angela. and the great effort and passion that you've shown in the program. And I can confirm to you, Dorothy, it's not just Angela, it's an entire team of physicians who support the GPAP program. They're a really committed team, and hearing that they do this work for free over the weekends, I think, thank you, and we really appreciate the work that they're doing. So Godfrey is saying, great presentation, hope Kakamega will be included in future. Godfrey, yes, so the plan is not necessarily to stop with the 4, but is to, to start with the 4 and see how the program performs, and then maybe, some of the other regional cancer centers can also be included. Edwin is asking, what are the chances of survival for patients at blast phase, and what modifications can be done on dosing to improve the conditions of the patients? Angela?
So blast phase CML is poor prognosis because these are actually patients with an acute leukemia, and it can be either an acute lymphoblastic leukemia or acute myeloid leukemia. Interestingly, CML is chronic myeloid, but the transformation can be either lymphoblastic or myeloid. So prognosis is poor. A lot of these patients don't survive. A lot of these patients require transplant. The dose modification is that a lot of these patients also require escalation of the imatinib from 400 mg to 600 mg, but that is not usually sufficient to take them into remission. So as I said, you'll still need to add chemo for this acute leukemia, and along with that, patient is likely going to require transplant.
Thank you for that. The next is a comment from Mapelu. A very good presentation, Daktari. Thank you, Mapelu, too, and your team with Enzo, the work you're doing to support the CML patients. Consolata is saying, thank you, Madam Angela, for the informative presentation. Then she's asking, how is herbal medicine affecting management of cancer in Kenya? Maybe CML in specific, or maybe broadly.
Well, the herbal treatment is being used in several ways. So patients either get a diagnosis and move straight on to herbal medicines and use those until either they die or are brought back to hospital with any complication. And then you also have patients who we are treating with conventional chemotherapy or targeted therapy, but they add herbal medicines to that without informing you. And so even when you develop complications or side effects or even death, you're not really sure or aware of this complication that the patient is also on herbal medicine. And so it's rampant, that's what I can say. And I always say that we don't have proper research. All medicines are herbal anyways, or at least started off being herbal, but we don't have any research to support the benefit in terms of outcomes of herbal medicine. So right now we don't have that information. I think it's a good area to look into and to study, but the use is rampant, and definitely we do get. Unfortunately, and again, if there are any herbalists in the group, you'll forgive me, but all my patients who are on herbal or have stopped their conventional treatment and gone to herbal have not done well. So I can only talk from that experience.
Thank you. So again, team, colleagues, let's counsel and support patients and provide very factual information. So Maureen is asking a question, well, not on CML, but Angela, we have some time, so maybe you can take it still. A 6-month-old child was diagnosed with retinoblastoma. What might be the cause? Is there any treatment apart from removal of the eye?
I think where it is primarily resectable, then that is what is going to be the primary treatment. So either exenteration of that orbit. But where it is not primarily resectable because of the extent of the disease, then chemo, but the chemo is just given for chemo reduction, just to say to reduce the tumor before surgery. I think it's not a lost cause completely, and I don't know too much about retinoblastoma, but for those who have had exenteration, they can still get an implant done. But I will stop there.
All right, thank you. There's another comment mentioning that it will be good if the support can be extended to second line as well. Then Joseph is asking whether nurses training he's asking about nurses training because they are 24 hours with the patient. And yes, training of nurses is critical and is key for any oncology training, even with the planning that I mentioned about. So training of nurses is part and parcel because of the kind of support that they need to give patients. Daniel is asking, why does B12, I'm assuming it's vitamin B12, increase in CML?
I will pass. I think that one I will need to check. I'm not quite
Okay.
sure.
Yes, and also I do know that again, we did mention that this is a series of three webinars. So the other two webinars will actually go deeper into the topic. So thank you. So I know that will be addressed in the upcoming webinars as well. So Geoffrey Njoroge, hello, I'm a CML patient. Can we assume more healthcare workers can confidently treat other diseases in a CML patient, especially when prescribing drugs? Because one may fear being given drugs that can interfere with CML treatment.
So Geoffrey, that's really an excellent question, because we always say imatinib is the one drug that has multiple drug to drug and drug to food interactions. And therefore, any doctor who is sitting in the mass or GPAP clinic really needs to read around the food and the drug interactions so that they avoid as much as possible drugs that can interfere with CML treatment. Beyond reading, I think is that aspect of can Novartis and Max and MOH look at programs for continuous professional development and CMEs that can help improve the capacity of doctors working within those clinics.
Okay, thank you. Dr. Rebecca Makichako is asking, if she's asking you to confirm if tyrosine kinase inhibitors or TKIs, especially imatinib, are available for free for patients with BCR, ABL positive, ALL.
Yes.
Thank you. Charles Nyaboga is asking again, I think you had another question. Can it be possible to ask Pharmacy and Poisons Board? Or I think that's his issues of the CPDs, and maybe I'll ask one of our support members from the KNH team to comment at the end. I know they've been showing some guidelines on how to get the CPDs. Again, another issue on CPDs, Mambuji is appreciating the presentation. Another question here, nice presentation, thanks. We realize that Novartis supports only the drug management for CML patients who later die from chemo-related problems like anemia and infections. Why doesn't the company assist the patients holistically?
Okay, so I think this is where we were discussing that we may need to look at other partnerships, including NHIF, to be able to fund these non-covered aspects, because Novartis as a company has truly supported by giving this drug that would cost millions per annum for a patient. I don't expect that our patients should be burdened with the additional healthcare needs. So I'm looking at how then do we, moving forward, look at getting in other partners who can support the labs and the complications and the side effect management.
Thank you, Angela, and I think I agree with you. We need to explore other partnerships and other forms of support for these patients. It's good enough that actually treatment is being offered for free. Usually for cancer management, the treatment bit is usually the most expensive. And as you saw, that these are very expensive drug without this access program. So I think as a country, we can also find other innovative financing models. And I'm happy because some of these will be discussed in the context of the overall cancer control, not just for CML. So there's a question from Josephine. She's asking why nilotinib, which is second line, is contraindicated in people with pre-existing vascular disease.
And I'll pass that one as well.
Okay, thank you. So again, it's mostly going to be covered in the third webinar that focuses on management and follow-up of CML patients. There's a question that again is not CML. What's the probability of pancreatic breast cysts turning cancerous? I don't know, Angela, if you can take that, but let me just also check for another CML specific question that you can take. Irene is asking around how many of your CML patients have NCDs and which ones are they? So I'm assuming that is asking about comorbidities. So patients who have CML and other NCDs, I'm assuming that's a question.
Wow, I think we didn't and haven't looked at that data, even in the registry, but it's quite important, especially considering how, treatment of CML and the interactions that occur with other drugs that are ongoing. So I think now that we have a registry, it is data that we should be able to add and analyze. We don't have that answer.
Okay, thank you. So there's a comment whether we can have webinars on GIST too. We're going to explore that. So Dana is asking, what would you comment on nutritional supplements in CML patients in addition to their usual medications?
Sorry, the question is?
She's asking if you can make a comment on nutritional supplements in CML patients in addition to their usual medications.
My comment, especially because there are multiple drug-to-drug interactions and drug-to-food interactions, is to avoid them unless they are completely unavoidable and your doctor and your nutritionist have consulted and given a supplement that will not interact. I think my blanket statement to cancer patients, and we have many people in this group, that we have so many myths around food, and patients are advised not to eat way too many things, and yet there's no proper link between nutrition and cancer. That's a fact. And so for me, as much as possible, CML patients should eat food that is natural and healthy and fresh and in moderate quantities. And they should be able then to get all the micronutrients that they require and not need supplementation from the more commercialized supplements.
All right, so thank you again. Another comment, one of our colleagues has been diagnosed with CML. A support group would be a good idea. Mapelo, I know you're with us. Could you unmute yourself and make a comment on that about Enzo? I don't know if Mapelo is still with us, but to just respond to that, yes, there's a support group, but I think Angela made a reference to it. It's called Henzo, and they do support patients with CML. So if you can be able to make contact with Henzo, then the patients should be able to get the support necessary. Rebecca is asking again, do we have provision to start young female patients direct to second generation TKI when we want deep molecular response when they express desire for fertility? So
that plan, we may not have it yet as the MASS program in Kenya, mostly because of the cost implications. But your point is valid, because we have many young patients. If you look at that graph around the age and the gender, we still have many ladies in the reproductive age, and they do want to get pregnant at some point in their treatment journey. And so it makes sense then to achieve your deep molecular remission early. And yes, the second generations do that, but the program currently doesn't cater for that.
Okay, Peter is congratulating you for the presentation, and thank you to you, Peter, as well, as being part of the GPAP physicians team. Juan Mapelu has actually commented to the participant who was asking the question. So Henzo Kenya support group is open and active in all the treatment centers. So please ensure engage of that particular patient to that. So I think from the Q&A section, unless not seeing, I think we've addressed all the questions. And thank you very much for your questions. And thank you, Angela, for taking time to respond to all of them in a clear fashion. It's as if you are actually prepared for all these questions, that if they had been documented and sent to you in advance for you to give direct and succinct answers. So thank you very much. And just before I move out of that session. Again, the issue about CPDs, we're going to request the KNH platform to check it out and ensure that people they receive their CPDs. I think a number of people are asking about CPDs this afternoon. So I think that's it. I hope I'm not missing any question here on this chat. No, okay, the issue about CPD. So thank you very much. I think I've not missed any question. So thank you again for taking time to attend this webinar. And again, want to thank Angela for taking time to take us through this first webinar in this series of 3. So just before we close, a few communications. One, again, is to reemphasize that this is a 3-series webinar. So the first one was an overview, which we've done today, overview of the CML treatment program in the country. The second webinar will be held same time on Thursday, 13th of April, 2023. So we are going to come up with a poster and circulate widely. And that will be focusing on diagnosis of CML. So some of the questions that are coming up today will be addressed that day. And then the third and last webinar will be held again on Thursday, same time on 27th of April, 2023. And that will be focusing on management and follow-up of CML. So again, allow me to acknowledge, a number of institutions that collaborate both to support the CML program, but also to make these webinars a possibility, starting with the JIBA program itself, the CML treatment program, with its entire team. Going to the Ministry of Health, especially the National Cancer Control Program, it's coordinating not just the support, the MOH support for the CML program, but also other cancer control programming in the country. And as well as KEMSA, I think Angela did mention that KEMSA is part and parcel. They manage the logistics of ensuring the medications are received and they reach the patients. Also thanking Kesho, the entire team of physicians supporting this program, and our members of Kesho. Also Hensel, I think it was mentioned again, has the patient support group and mechanism. Again, it's available in all the centers, ensure that patients are linked to this support group. In a major, we want to thank Novartis. So Novartis, both in the overall support of this program, but also in the support of these webinars, making these webinars possible. We also want to thank KNH and UN research departments for making available this wonderful platform for us to be able to disseminate this. And also, again, in a special way to thank the presenter for us this afternoon, Dr. Angela McLeod. With that, I don't know, maybe the KNH team, any points, do you want to make a comment, or the communication you passed about the CPDs is enough? I assume that means that the information that you've displayed is enough. So everybody who has any challenge with the CPDs, kindly follow those channels to be able to sort out that. So thank you very much for joining us today. Hope you're going to join us in the remaining 2 webinars in this series. Have a great afternoon.